Hello, everyone. Welcome to another Friday VMR. Really excited to co-discuss with another hospitalist, AMK, who's been a long-standing member of the team. AMK, how long have you been part of CP Solvers?
So I actually started, it was my third year in residency when COVID started. So I'm a COVID original.
Wow, and that's 6 years. That
Yeah,
doesn't feel
yeah.
that way. Yeah. Wow. Well, really excited to co-discuss with you. And helping us do the scribing and teaching points today. Seema, you want to say a word?
Hi, I'm very excited for discussion today, and Yusuf and AMK are both looking very nice in red today.
Uh, yeah, thank you,
No,
Seema.
it was not planned.
It was not planned. Krishna, you want to say a word?
It's my first time scribing, so I was told that Simi is one of the best scribers out there, so please have my back.
We've got you, Krishna. Don't worry about it. And lastly, Hans has also been part of this community for a while now, and we're wearing red for his fire case that he's about to present. Hans, you want to say a word?
Yeah, good morning, and it's an honor to present yet another case. And today's will be, I want to say, a bread and butter case, and very logical, I hope so, with a lot of learning in it. And when you're ready, we'll start with aliquot number 1.
Yeah, let's do it. We're ready.
Yep. This time I have a 60-year-old male, and he presents with abdominal pain. It's actually severe abdominal pain, according to him, with fever for 1 week. And more information will be given in the history of present illness after this.
Yeah, I can just start out with a few thoughts. So it's kind of a middle to older male with abdominal pain and fever. I think if their abdominal pain was present without fever, it would be a little bit harder to say, is this an inflammatory or a non-inflammatory case? But the fact that there's fever here, I'm really going to be kind of like thinking about an inflammatory syndrome. I think that we don't have a lot of information about where in the abdomen it is. I think where the abdomen can fake you out or abdominal pain is that you don't want to forget about like the thorax and like what is adjacent to the abdomen, because sometimes that can be superimposed. And then yeah, like there's a lot of abdominal structures that as we get more information, I think will help us hone in based on where the abdominal pain is, how it's described, and also the past medical history of the patient, and like what structures they may or may not have because they've been surgically removed. So really interested to hear, is this some sort of itis of some structure like pancreatitis, cholecystitis, appendicitis? Is this some sort of like infarction or twisting? One would have expected, since it's been going on a week, that this may be a more indolent process that has higher tolerance, and a lot of times vascular phenomenon would not have that tolerance, but every once in a while you can kind of get this waxing and waning course or something like that that could be the case here. And so you definitely want to be like thinking about those risk factors, and then also like what could get infected in the abdomen. So not just itises, but also could there be an abscess somewhere, or cystitis, or a pyelonephritis where there's an actual infection there. So I'm excited to get more information and make progress on this case. Yusuf, anything else you have to add?
I love how with abdominal pain we like go through the VIPO like acronym quickly, but then when you add fever to it, it's very sharpens it specifically to the eye, which is like the itis, like you said, which an acute fever should almost always make you think of infection. So we're honing in on that, and I'm trying to think if I can take it even further. Like cholecystitis, I usually think of like premenopausal women. I don't think like necessarily he would be like a higher risk for cholecystitis unless we have like any other risk factors that we'll hear about shortly. I love the idea of like also like pyelonephritis. Could that be on the differential? And then one thing that I specifically remember is whenever you think of abdominal pain, look up and look down. So look up, like AMK said, like could this be like a PE or an MI? And then look down at the genitourinary tract, which we're doing, and then adding on the fever, so going through that tract. So really excited to hear more, Hans.
Yes, and the history of present illness will give you the location. The patient describes the location of the severe abdominal pain in the epigastric region and the right upper quadrant. The pain is associated with fever, fatigue, and a headache for 1 week. The patient also reports that he has had a diarrhea for over 1 year and that he noticed mild abdominal pain, which, as described above, has gotten worse in the last week. The diarrhea is mildly loose, non-bloody, and he has 2 to 3 bowel movements a day. He denies vomiting, weight loss, or cachexia, severe weight loss. The diarrhea gets worse with fatty meals that he found out over time, and it improves with a low-fat diet. And now the patient describes his stools as oily and they float. When he flushes the toilet, a greasy film remains, and this requires a second flush. And the patient also, he denies drinking alcohol. He does not smoke, but he likes drinking coffee, and he's so afraid and HBI that he's drinking too many cups of coffee. This, he believes, could be the reason for his condition. And that is aliquot number 2, and I'll continue with past medical history after the discussion.
Wow, I love it, Hans. Such rich information and such detailed history taking. And whenever you think about abdominal pain, you think about the quadrant, and then you imagine the what are all the organs that go behind that quadrant. So whenever you hear right upper quadrant, you want to consider the gallbladder and the pancreas and the other structures that go around, like the colon and the small intestine. I love the combination of diarrhea. And to everyone like listening, how does diarrhea influence that, adding that to abdominal pain? And whenever I think of vomiting, I think of the upper tract. And whenever I think of diarrhea, I think of the lower GI tract. And we hear about symptoms that sound malabsorptive, right? We hear about fatty stools, the stools rising to the top, and then diarrhea associated with meals, with fatty meals. So you're wondering, is this a malabsorption syndrome? And could there be a deficit in the gallbladder or the pancreas for whatever etiology? And I would love to brainstorm with AMK. What could this be? Like, what could this patient have in their background that would make them be have issues with their pancreas or with their gallbladder? And because the classic presentation is somebody has, for example, years of alcohol use, and then suddenly they develop a syndrome. We're like, okay, they're having chronic pancreatitis, and now they're developing acute on chronic syndrome. And that's the classic presentation that I see, but would love to brainstorm what else could it be if we don't get that history. And in general, when you think about diarrhea, you want to think about inflammatory versus non-inflammatory. And we don't hear about any inflammatory symptoms here, and we hear about malabsorptive symptoms specifically. And initially, because when I initially heard diarrhea, I was like, oh, could this be like an IBD syndrome with a concomitant gallbladder disease, which there can be co-inherited if you have, let's say, ulcerative colitis. But we hear here it's malabsorptive. So AMK, how are you merging the two? Or other than alcohol use, what other etiologies do you think of for malabsorption?
Yeah, so I think the question here is, as you alluded to, is where is the problem? So what do we need to digest fat? As you said, bile. So we need the bile from the gallbladder, we need pancreatic enzymes, and then we also need a working lumen. And so if you think about that, I think we're going to be questioning, assuming this really is fatty stools, which it does sound like. You might have learned like stools that float don't necessarily correlate, but the film that you see on there sounds very much like a fatty stool. And so I think we're going to be thinking about like where in the track is that problem, and how does this problem perhaps like overlap with the current problem, assuming that they're related, which they could not be, because people can have two things. And so, yeah, I'm going to be very much thinking about like, is there a working pancreas? And as you said, the most common scenario that we see is alcohol use disorder causing chronic pancreatitis. But you could also have like an idiopathic pancreatitis or like a familial, like IgG4 pancreatic cancer as well, is like always a do not miss diagnosis that can be very subtle. And then I sometimes see patients like with things like cystic fibrosis, that can also cause it. So I'm really curious, like I really want to know, has there been prior pancreatitis or conditions that could like be concerning or overlapping with that? And then or like hypertriglyceridemia too. So curious about that. And then I think I'd also just be asking about things like weight loss, thinking about like, could this be some sort of luminal problem? The most common luminal problem I think about is celiac, which this patient demographic wise is a lower risk group than I often think, but there can be kind of other luminal inflammatory states or like a Whipple's disease or something like that, which it doesn't sound like we're given lots of history, and that's a very uncommon esoteric diagnosis. But there can be kind of other luminal problems that exist as well. And then, yeah, like getting more history, like, do they have a gallbladder? If so, like, do they get pain after fatty meals? Because if it was on the gallbladder, one would expect that one, aside from just having fatty stools, one would also feel symptoms after fatty meals. And so, yeah, those are kind of how I would think about and potentially merge the issues.
I love it. Yeah. And only CP solvers bring up like cystic fibrosis gene whenever we hear about pancreatitis. I love it. But I love how you framed it as all the etiologies of pancreatitis, but recurrent. And then the other category you mentioned was infiltrative into the pancreas, so like cancer and IgG4. And celiac can cause pancreatitis because it can affect where the gallbladder goes into the gut. And if it affects that region, it increases the risk of pancreatitis by like 10 to 20%. So believe it or not, even celiac disease can cause pancreatitis. And I love what somebody mentioned in the chat is like, if you have fat malabsorption, you can have like oxalosis and oxalate disease, and that can cause like kidney stones, and that can get infected. I think we delved a lot, Hans. Would love to hear more from you.
Yes, the next aliquot is the past medical history. And he had a colonoscopy done as part of his usual screen 5 years ago. And they found a diverticulosis, but nothing else. Random biopsies, everything normal. And he has no medical conditions. Medication, no medications. He occasionally takes some multivitamins. The family history is unremarkable, and the social history is pretty much unremarkable as well. He's married, works in an office. He does not smoke, as mentioned before. He does not drink alcohol and no recreational drugs other than his coffee. I can continue, if you like, with a physical exam because it's where we get some information. His vitals. There we have a temperature of 102.2. I think that's 39 degrees centigrade. His blood pressure is perfect of 100/70. Heart rate is 110. SO2 is 98 in room air. General inspection. He has signs of jaundice and yellowish skin, and that is noticed in his abdomen. We have tenderness in the epigastrium and the right hypochondrium, so right upper quadrant. The Murphy sign is negative. His lower extremities show mild bilateral lower limb edema. The skin, and that was really noticeable, has decreased elasticity, and the patient is markedly dehydrated. Heart and lung are normal. And I stop here. And next will be the labs.
Okay, so I think I can comment a little bit on the past medical history. And then I'll let Youssef talk about some of the exam findings. And then we can maybe kind of come back and put it all together. So I would say thinking about the past medical history, there's not a lot there, which is helpful in that, if there was a lot there, it could lead us in a direction. But I think that we have to kind of start new here. I will say that when you think about fatty stools, you're really going to be thinking more about because you think about what does each organ do, the small intestines, because a lot of the large intestines, their job is going to be water reabsorption and forming the stools. So I do think this is probably more of a problem in the small intestines. That being said, if someone has chronic diarrhea, it's always important to think about the colon. You can get a collagenous colitis, something that you can't always see on the surface. And so I think it's always good to be thinking about the colon, having a biopsy as well to make sure that you don't see some of these microscopic colitis states. But I think that here we can still think could the small intestine still be on the hook? Because it sounds like at least there was just the colonoscopy, and I'd have to say yes. Although as we get more information about the jaundice, that's going to, I think, help us a lot in localization and thinking about where this process could be going. The fact that they're not on any meds, again, is reassuring. It helps us to say hey, we don't think this is a med problem. Kind of just things to upload with meds and diarrhea, other than the obvious of bowel regimen is olmesartan can cause a enteropathy and can cause very bad malabsorptive diarrhea. And so it's reassuring that it's a common medication so that the patient isn't on this medication that could be contributing to a diarrheal illness. And then, otherwise, we're not, again, getting a lot of kind of direction one way or the other, like alcohol or a significant tobacco use history. And so I think we're really going to be relying on the clues in the exam and the presentation to guide us on next steps. So Youssef, what are you thinking as far as exams and labs? Or sorry, and not labs. And PE
Yeah.
and vital signs.
Yeah, I have a lot of thoughts. I was thinking of doing a 2-minute breakout room before I give my thoughts. But the question for the breakout room is, let's say you have all these tools at your disposal. So you have ultrasound, CT scan, MRCP, HIDA scan. In what order will you order these tests? And let's say you start with ultrasound and it's negative. What would you do next? And if that test is negative, what would you do next? So what order of tests do you want? And you have the power to order whatever you want because you're the resident on call. And so I'm going to give you that power now, so you can discuss that in the breakout room, and then we'll come back and then we'll chat. Welcome back, everyone. Just wanted to go through a quick point here is that this patient presenting with chronic malabsorption, now with acute fever, jaundice, and right upper quadrant pain. And the schema we're thinking about or wondering about is hepatic obstruction, right? Whether intrahepatic or extrahepatic. So that's the big schema. And we're zooming into the biliary tree to see where the obstruction is and what's causing the obstruction. And the really important point I wanted to make here is that the pretest probability here of a gallbladder disease like cholangitis or cholecystitis is really high. And it's really, really important to know the test characteristics when you order the test, because right now you're going to see the patient and you're going to put in an image on an order to see what scan you want. And whenever you order a test, you need to know the pretest probability, so you know if the test comes back negative, what should I do next? And the sensitivity for gallbladder disease, so ultrasound has actually a low sensitivity, so does not necessarily rule out an obstruction. And then next you go with HIDA scan or CT with contrast, which have even a higher sensitivity. And the next step is an MRCP, which has a higher sensitivity, and then the highest sensitivity is ERCP, where they go with an endoscope through the mouth and go get an ultrasound and look through the ultrasound into the biliary tree. And I'll share let me find the schema. Okay, I'll share it in the chat. We have the extra hepatic biliary obstruction schema, which you can see there. And you can see the sensitivity of the tests on the schema as well. So how do we relate the acute finding with the chronic findings? So this patient has chronic malabsorption, and now we see symptoms of possible cholecystitis, cholangitis, And AMK brought up the idea of a clot as well, so I'll throw the mic to her after as well. So I'm thinking, could there be an obstruction on the biliary tree that's slowly been compressing the biliary tree, and that's caused the bile salts not to go into the GI tract, and now possibly the accumulation of bacteria behind that obstruction. So could there be like bacterial accumulation behind the tract, and that's what we call cholecystitis or cholangitis. And this patient requires like an urgent workup with like the imaging tests, and the pretest probability of cancer significantly goes up just because of the age of this patient. So he's a 60-year-old male, which makes stones less likely. So you really want to consider malignancy. And could this malignancy be slowly obstructing the tracts? And that's causing malabsorption. And now bacteria is accumulating behind it. And whenever you also are worried about the cholecystitis or cholangitis, you want to have an early surgical consult. And then you want to stick with your hypothesis and go through the tests one by one, even if the initial test is negative. So if the ultrasound is negative, you want to pursue further testing. You want to talk to your surgical colleagues and have early interventions. AMK, what are your thoughts?
Yeah, I definitely agree with everything that you said. And I do think the like kind of elephant in the room is there cancer? Of course, there's a lot of biliary pathology that or pancreatic pathology that could cause like a slowly progressive course that could then crescendo if you got like a cholangitis or something like that, like a stricture that could be benign, but like with the age and everything, I think the pretest probability of cancer is really high. One thing important to remember about malignancy, like obviously like we treat the syndrome in front of us, just like kind of for knowledge, is that oftentimes like in pancreatic malignancy or biliary obstructions caused by malignancies, there is lower risk generally of cholangitis, just because it usually causes a complete obstruction, so bacteria can't transverse past. Whereas with like stones, the risk of cholangitis is a lot more because it's not like a complete obstruction, so bacteria can get back. That being said, no matter what the etiology is, we have fever, we have a patient who's tachycardic, who I'm very concerned has like impending sepsis. And so I would definitely be like treating this as a possible like cholangitis case, while I'm gathering that information and the surgical consulting my GIT, like while, getting all the labs and everything like that. And also the imaging modalities to help us move forward in this case. I do like think that another possibility would be, and these are not exclusionary, these are like just things I think about, is if there is a possible cancer there, that there could be a clot there as well. I see that commonly. And so that's also something I'm going to want to be thinking about. And like when I get the imaging, really review that to see if there's any, clot there as well. So I am very curious to see what the labs and imaging shows. Youssef, what imaging, acknowledging the limitations, what imaging modality would you start out with?
I think only because like how quickly we get them in our institution, like we can get ultrasound and CT like very, very quickly, while HIDA and MRI take a little bit more time. So I think one of these two, just because of practicality. Yeah. What about you?
Mm-hmm. I think I would probably start out with CT with contrast. And ultrasound is a great test generally, but I think in this case, I'm just so concerned about an inflammatory cause and like wanting to see, is there either cholecystitis or signs of cholangitis, and then also wanting to see the vasculature. And I think that would give me a lot more information than the ultrasound would in this case. So I would probably start out with that, and then also be thinking about MRCP as well, depending on what happens. But obviously that's going to be institution dependent, resource dependent, and everything like that.
I love it. Back to you, Hans.
Then I continue with the labs. We have a CBC. The WBC is 13,000. That is elevated. A hemoglobin is 9, an MCV of 885. and a platelet of 400,000. Chemistry was completely normal. And because the patient had signs of jaundice, liver function test was done.
Yeah, I think Hans might have cut out briefly. I start again with the labs. The CBC, we had a WBC of 13,000. We had a hemoglobin of 9. We had an MCV of 85. And we had platelets of 400,000. The chemistry was completely normal. Because of the jaundice, liver function test was done right away too. And there we had a GGT of 500, an ALT of 100, an AST of 110, an INR of 1.3, a total bilirubin of less than 0.3, an alk-phos of 400, and amylase and lipase, because of the greasy stool, was done as well. And the amylase was 190, the lipase was 160, and fasting blood glucose was normal at 90 milligrams per deciliter. Because of the symptoms of the patient, a little bit of serology was done as well. The fecal calprotectin was measured, and that was 40 microgram per milligram, which is in the normal range, which is 10 to 60. An anti-endomysial antibody for celiac disease, and that was 0.1, and the normal range is from 0 to 0.1. And the thyroid was tested as well, which is totally normal. And I also have a urinalysis, which is completely normal. Patient had no protein, no glucose, no ketones, and no microalbuminuria. The stool, no occult blood, and no parasites. And I stop here before I continue with the imaging. Okay, so a little bit of a plot twist. We do have the inflammation there, which we were suspecting with the fevers. And so I think we still have the question of where is the inflammation and how do we treat and address the inflammation, which labs will give us a little bit more information on. The hemoglobin of 9 is interesting. It looks like the MCV is normal. I'd be very curious historical trends for that, to say, like, is this malabsorption related to vitamin deficiencies? Is this chronic inflammation decreasing it? Or is there some sort of like loss or destruction at play, which we can get more information on? I tend to think it is probably an effect rather than like the causal thing that's going on here, of kind of all the other inflammation. But again, we can look more into that and see. The elephant in the room is the liver enzymes, which, show that the liver enzymes are inflamed, but the normal bilirubin is very surprising here. So, Youssef, do you have any other thoughts on that?
The only thought that I had was like where I commonly see this is in patients with cholelithiasis who had choledocholithiasis, and then that caused the like a bili to be high, cause maybe gallstone pancreatitis, and then the stone passes. And I see sometimes the AST and ALT lagging, like still being high, while the bili like normalizes slowly thereafter. And I see that where like the stone passes, but the damage is already there. So like the bili maybe normalizes, but the AST is still high. Maybe they develop some pancreatitis or gallbladder disease, and we see the remnants of that. So we can clarify that with Hans if the actual T bili was low, or was it the direct bili that was low. So that would be important to know. And the tricky part here was like initially I was focused on like could this be like cholecystitis, but now we're hearing that the amylase and lipase are I think are like is the lipase high, Hans, as well at 160? Because in our lab the upper limit of normal would be like 50, so 160 would be close to like 3 times the upper limit, but I'm not sure in your lab how it is. So I'm wondering if this was like a transient etiology, and AMK, are you thinking this could be pancreatitis, or do you think this could be still like gallbladder, like bacterial infection, or what are you thinking is the acute component of the syndrome?
Yeah, I think I definitely, if the bilirubin is like retested and is indeed low, I think I am maybe like shifting my thought process a little bit more to say, like, as you said, was this some sort of like transitory effect, like a past stone or something like that that caused inflammation, something that could affect, as you think about biliary drainage, when you have the like common bile duct and then you have the pancreatic duct coming off, and then up here it's like you have gallbladder, cystic duct, so something that could affect both, and cause a little lipase elevation as well. I think it's a little hard not knowing the reference range because, again, generally pancreatitis, it's 3 times the upper limit of normal. Compatible pain, which maybe, but it doesn't seem like a slam dunk. It's like there's some epigastric pain. I don't hear about it like to the back, and it seems like could this be gallbladder 2 and then imaging in 2 out of 3. So I think I really need more information before saying like, is this the like pancreatitis per se. I will say that like because again of that shared duct system, sometimes you can get like something that irritates it, but maybe it doesn't fully cause pancreatitis, that because if there's a little bit of transient obstruction. And so I think that sometimes if you see that and you also see elevated liver enzymes, it could be a clue of like maybe a kind of a shared irritant there. I will say lipase can be elevated in a variety of conditions. And so, that's why we have those criteria for pancreatitis. So sometimes just really bad, like nausea and vomiting, diabetes, kind of other things can irritate it as well. So I'm going to want more imaging and further information. I definitely think with the ALK phos elevation and GGT, like we can say there is something that is amiss in the biliary tract, that seems to be going on. But without the bilirubin elevation, it is like a little less clear what exactly that may be. But I still would want more biliary imaging to move forward.
Yeah, I agree. And the other thoughts that crossed my mind initially was like, could this be hemolysis causing stones? But we hear that the MCV is normal. So if the MCV was low, I would have considered like genetic traits, like sickle trait or thalassemia trait. But and then if the MCV is high, I would consider active hemolysis. But the MCV is normal, so maybe this patient has some vitamin deficiency from
Yeah.
the malabsorptive state, maybe like as a consequence. And then the other thing I was thinking that crossed my mind was like, could this be like PSC? Could this patient have like a component of that, like an autoimmune component causing this like chronic inflammation as well?
Yeah, I definitely think that certainly I've seen hemolysis with normal bilirubin. And sometimes a clue can be because AST is more than ALT. So if the AST is elevated but the ALT isn't, that could certainly be a clue. But I think kind of for the reasons you mentioned, there are several reasons why kind of like the normal bilirubin, the AST to ALT ratio, and kind of having other things going on that makes me think hemolysis is less likely in this case.
Back to you, Hans.
I think then we can continue with the imaging. I have a few pictures and I could try to share them. And if not, I'll give you, that's the first one. The first ultrasound abdomen, which shows the belly. And I have a few more. That's the second one. And the third one. And for the CT, we had to wait until the patient was stable enough, and that I'll show later. Those are the three. The official read is we have a dilation of the biliary radicals and dilation of the common bile duct, which measures 8 millimeter in diameter, but we have a normal gallbladder and a normal gallbladder wall.
Hans, can you pull the third image back up that shows the gallbladder?
Yeah.
So oftentimes, like when you're looking at the gallbladder, some things that you can see on ultrasound is if there's stones, they'll look like kind of hyperechoic, and then oftentimes you'll get posterior acoustic shadowing. So it'll be like kind of more prominent after that. And then the other things that you can see that the gallbladder isn't happy would be if the walls are thickened or there is fluid, so the pericholecystic fluid around the wall. So here you don't see like the obvious like thickened wall or fluid around the wall. And so, that kind of makes you think like there certainly, that's not the end all be all, but those are kind of clues that either there's cholecystitis or the hyperechoic with posterior acoustic shadowing can be a clue of cholecystitis or cholelithiasis, so stones there.
Awesome. I love co-discussing with the ultrasound expert.
Yeah.
Makes it so much easier.
I'm not at all. I'm a very novice. And then you can see here, kind of when you look, again, like I don't know if I would have felt comfortable calling it, but on the first image, you can see that there's hypoechoic kind of black areas in the liver itself that you're like, what are those? Those look like kind of out of the ordinary, which I think are the dilated ducts that you see. So very interesting.
Yeah, I love it. And I was thinking of like we have confirmed CBD dilatation now, and what is causing the CBD dilatation? And we heard about the stones hypothesis, and stones are going to be like very, very common, and especially in the right like patient, and that's where you want to like keep following the hypothesis and consider further imaging. And then the other etiologies we considered were like, could this be a cancer or could this be like an intrinsic autoimmune disease? And I think getting further imaging is going to be really helpful with a CT or MRCP if the CT does not show anything, and following this pathway all the way to the end. Hans, what happened next?
Yes, because of the high WBC, the patient was first of all treated with an antibiotic, piperacillin tazobactam, for 6 hours with massive rehydration, and they prepared him for an ERCP, referred for biliary decompression, there's something going on. So the ERCP result I can give, and an additional test was also done. So the ERCP result, we had distal common bile duct stricture with sludge. Then a biliary sphincterotomy with stent placement was performed, and that drained the biliary system. We also did an additional stool test, fecal elastase, because of his greasy stool, and the fecal elastase was 90 microgram per gram, and that is lower than the usual, which is more than 200. And the fecal fat level was done as well, and as expected, it was high. It was 12 grams over 24 hours, and it should only be between 2 and 7. And I stop here because the patient has some hospital course complications, which I want to mention.
Yeah, I wonder if we should just keep going through AMK. Do you agree?
I mean, do we want to take a moment and talk a little bit like about strictures and what strictures could be?
Okay,
Or
let's do that.
or no? Um, I mean, so I think the really big question is if there's a stricture there, why it's there. And strictures can be like benign or malignant. So hoping that they're able to get some pathology to review from that structure. Benign strictures can either be because there have been instrumentation before. So like someone who's gotten like their gallbladder removed or something like that. They've been in the area, or someone who has like chronic pancreatitis. So there's lots of inflammation in the area. So that's kind of like instrumentation, inflammation, and then also like other autoimmune or inflammatory diseases. But this seems very focal. So it doesn't seem to me as much like a like sclerosing cholangitis, which usually you associate like with other autoimmune diseases, like inflammatory bowel disease or like a PBC also doesn't really seem as much, not that demographics make or break a diagnosis, but as kind of the demographic. And so I'm definitely going to be like, is this a malignant structure or is there some sort of like chronic inflammatory cause there? Any other kind of etiologies that you think of with strictures?
Yeah, no, not a lot to add. I think I would like also rely on like the ERCP and see if like a biopsy was done or if that could be done. That could also sometimes be like very, very helpful as well.
Okay, then I continue, and I think you already got the first diagnosis, which, based on the stool findings, the last ones, was exocrine pancreatic insufficiency due to chronic pancreatitis, which then in turn caused a superimposed acute cholangitis with a stricture. Now, during the hospital course, about 2 days after admission, the abdominal pain of the patient shifted from the right to the left upper quadrant, and he had severe tenderness and guarding and dyspnea with every inspiration. It was then that we did an abdominal CT, and I could just come to the conclusion now. The patient also developed during the hospital course a splenic, and that is very rare, a splenic hematoma with which was later found, a splenic vein thrombosis from the acute inflammation of the pancreas. So we have splenic hematoma with acute splenic vein thrombosis. Pancreas shows radiologic signs of chronic pancreatitis, which was then completely confirmed. Irregular calcifications, so a long-standing chronic pancreatitis, loss of normal texture of the pancreas, and dilation of the pancreatic duct with no focal lesions. So the complete diagnosis was we had a chronic pancreatitis with superimposed acute cholangitis and subsequently a splenic vein thrombosis, and that indeed caused a splenic hematoma at the end. The last sequelae is a little bit rare, but it's just a logical flow which can happen. And we have a final CT picture as well, if I could just show that one. And there we see the splenic hematoma.
Hans, I'm not sure if this is like the final. Did they ever figure out like what they thought caused the chronic pancreatitis?
That is exactly the question that I had as well. I have not found out because he's not on alcohol. He never had. What caused it in the end, I don't know.
And do you know, yeah, and thank you. This is an absolutely amazing presentation. I was curious, you know, if they sent IgG like 4 levels, or if when they did the ERCP, if they did an EUS to like look and see if they saw any masses or anything that could be biopsied?
No masses and no IgG4 was done. That would be a very good explanation for chronic pancreatitis as well, but I don't have any such information.
Yeah, thank you so much, Hans. And like AMK, AMK put out the great schema of chronic pancreatitis. The two big buckets we said either recurrent pancreatitis or infiltration. We did not hear about any etiology about recurrence, so we were wondering about infiltration. And under infiltration, you worry about is this macroscopic or microscopic? So macroscopic, we looked at the CT, we did not see any masses. So now we're wondering about microscopic. So we considered like, could this be like a malignancy? Could this be a related disease? And sometimes it's like an autoimmune, like PSC we mentioned earlier, it's like microscopic, and rarely it's also like genetic. I think that would be the last thing I would add to the schema is genetic predisposition, like cystic fibrosis excessive. In this case, maybe we didn't find out at this point, maybe we'll find out in the future, but I think it's a really, really helpful case to go through the etiologies, go through acute inflammation, acute cholecystitis, pancreatitis, and think about approach to imaging and all the etiologies. Any other reflections, AMK?
Thank you so much, Hans. Like this is such a great case, so rich in learning, and I really appreciate you bringing that. And yeah, it's definitely a kind of interesting set of events with, having that structure there that was probably from the chronic pancreatitis, but just kind of that uncertainty there, and then being like, there's jaundice, but there's no bilirubin. So definitely a lot of twists and turns, and appreciated it. But I think at the end of the day, just kind of like going with like what you know and like what's the next step that makes sense at this juncture to get to the diagnosis, and just kind of taking everything systemically and be like, why was there these fatty stools? Like what caused that? And then, just kind of taking it one step at a time.
Yeah. Simi, can't wait to learn from you.
Yeah, thank you so much, Hans, for such a wonderful case, and thank you, Krishna, for scribing. Thank you, MK and Yusuf, for such wonderful discussion. And I'll not go through everything, but just two key points. That when we have fever and abdominal pain, we think more of I part in the hypomnemonic, and when we have diarrhea with abdominal pain, we can focus more on malabsorption and lower GI tract structures. And we found that the patient had chronic pancreatic insufficiency here. Thank you so much, everyone, for joining us.
Have a good Friday.